very good evening. I am Dr. Yamuna Devi, consultant in infection control, Apollo Hospital. My today's topic is on basic microbiology. A 48-year-old female patient comes to the OP with a pus sample growing gram-positive cocci. What should be the empiric antibiotic of choice? So my objective of today's talk is gram stain, morphology of the bacteria, the common commensal flora across the body, and also the clinical significant bacteria which we need to understand for a proper antibiotic of choice. So the easiest way of classifying a bacteria is based on the gram stain, gram positive and gram negative depending on the primary and the secondary strain. The basic difference between a gram positive and a gram negative bacteria is the thickness of peptidoglycan layer. The peptidoglycan layer is much thicker in the gram positive bacteria as compared to gram negative. In the gram-negative bacteria, there is presence of an outer membrane beyond the peptidoglycan layer. The outer membrane constitutes of lipidae and polysaccharide, which forms the endotoxin, and also the porine channel through which all the nutrition as well as the entry of the antibiotics happens for the bacteria. The subunits for cell wall for the peptidoglycan mechanism remains the same for both gram-positive and gram-negative. It is alternative subunits of N-acetyl-glucosamine and N-acetyl-muramic acid. Further, these subunits are linked with each other by the interpeptide chains and also by the tetrapeptide chains. The major difference between the gram-positive and gram-negative relies at the level of 3 amino acid. Usually, the bonding happens between amino acid 3 and the subsequent amino acid 4 by the presence of pentaglycine. The pentaglycine forms the major cross-linkage between the two layers. This happens in the presence of an enzyme called as penicillin binding protein. The process is called as transpeptidation. This is a very major mechanism by which the thicker and thicker cell walls of the gram-positive or the gram-negative bacteria happens. So this is a pictorial representation of the cell wall mechanism where the grey colored shaded zone shows the presence of transpeptidation or the penicillin binding protein, where the first picture states us about how a beta-lactam drug goes and binds, whereas the second picture shows us if there is a problem in the penicillin binding protein, the antibiotic does not bind at the site properly, which leads to the mechanism of resistance in the bacteria. So moving on to the different types of gram-positive and gram-negative bacteria. Based on the arrangement of organisms or the shape of organisms, they are called as either a cocci or a bacilli. In cocci, based on arrangement, they are differentiated by different names. For example, the cocci which are in clusters mostly seen in Staphylococcus. It can be aureus or it can be a cons generating Staphylococcus. The second, tetrads, most commonly seen in Micrococcus. Third, Streptococci. It can be in pairs, short chains or long chains. And Enterococcus. Gram-positive bacilli, we also call them as gram-positive rods. The different examples are Corynebacterium, Clostridium, Bacillus, Listeria and Lactobacillus. Among this, the Listeria plays a major role as a pathogenic bacilli. Gram-positive and branching filamentous bacteria, Actinomycetes group, which is Actinomyces, Nocardia and Streptomyces. Gram-positive budding yeast cell, they are not a bacteria, but basically they are Candida species, which also takes up the gram-positive staining. A very high specificity for some community-acquired syndrome. How does this gram stain help us out? The gram stain helps us to differentiate between the bacteria and choose the right antibiotic right at the level of diagnosis. For example, if a urethral discharge gram stain shows the presence of gram-negative cocci, it could be due to Neisseria gonorrhoeae. A well-collected sputum sample, if it shows a gram-positive cocci which is capsulated, it could be Streptococcus pneumoniae. Community-acquired meningitis can easily be picked up in the CSF gram stain. If it is a gram-positive bacilli, it could be Listeria. Useful to direct therapy, especially in gram-positive culture specimen. The second group of organisms, that is anaerobic. we can also differentiate bacteria based on their physiological requirement, that is, which is dependent on the availability or the presence or absence of oxygen. There are two subsets of bacteria also in this, gram-positive and gram-negative. The first one, obligative aerobes. That means they do require oxygen for their growth. The second one, facultative anaerobes. They can grow even in absence of oxygen. Obligate anaerobes, they do not require oxygen. Aerotolerant anaerobes can survive in presence of oxygen. Microtolerant, they require a very low concentration of oxygen. So which are these bacteria? Among gram-negative, there are bacteroids, Prevotella, Fusobacterium. In gram-positive bacteria, there are Clostridium, Actinomyces, Bifidobacterium and Lactobacillus and many more. What is the clinical significance of an anaerobic bacteria? If you see certain bacteria in a gram stain and it doesn't grow in a culture, probably it is an anaerobic organism. And if there is a persistent of infection, your patient is not responding to the appropriate treatment, probably he has a co-infection with anaerobic organisms. Infections of specific body sites, which is a deep-seated infection like endocarditis, a brain abscess, a prosthetic device or a graft infection or an intra-abdominal abscess, long-term therapy is always needed in an anaerobic infection. Election of an active agent is critical for a disease management. Now moving on to the resident flora or the common commensal. What do you mean by that? Resident flora or common commensal are the bacteria which is already present in your body wherever at the opening sites. For example, the oral cavity, which is opening into the environment, always has a commensal bacteria. The second commonest area is the nasal cavity. So these are all the normal bacteria of our body which always helps us out in preventing overgrowth of pathogenic bacteria, which we call it as microbial antagonism. The burden of commensal or normal flora is highest at the level of your GI tract, and second, it is highest in the axillary or perineal region and also at the scalp level. The reason why we need to understand the burden of commensal bacteria is after isolating bacteria every time doesn't mean it's a pathogenic organism. We have to keep in mind about the commensal bacteria also. Which are all the normal flora of human? For example, if we take skin, we do have multiple gram-positive bacteria sitting on our skin, like Staph aureus, it could be Bacillus, or it could be a Corynebacterium, Streptococci, or Micrococci. Among the fungi, the common one is always the Candida. The upper respiratory tract also has similar gram-positive organism, whereas the lower respiratory tract is preferred to be a sterile zone. Similarly, in the oral cavity, we have multiple anaerobes and gram-positive bacteria. The GI tract is the main area where we constitute the majority of gram-negative organisms. The load of microorganisms are higher in the lower GI tract. This is a picture depiction about the resident flora in the gastrointestinal tract. The upper GI tract is almost sterile, whereas you do have some amount of enterococcus in that. But the lower GI tract is where it is fully burdened with gram-negative bacteria like E. coli, Klebsiella, all groups of Enterobacteriaceae. The anaerobes like Clostridium, gram-positive cocci like Enterococcus. So the most common normal commensals are coagulase-negative staphylococci, diphtheroids or the Corynebacterium, Candida, which is among the fungi, Micrococcus and Streptococcus viridans. Why we need to know this? Whenever we isolate such organisms in culture, we have to be very sure about the pathogenicity, that which are the organisms we are going to treat. Moving on to the colonizers. Colonizers are not similar as the normal flora. They are the bacteria which lodge during the admission of the patient in the hospital. So these organisms are at a level which is normal, which would not provoke infection unless and until the immunocompetency of the patient gets compromised. So never treat the colonizers unless and until there is a clinical correlation for the patient's condition. Contaminant. So contaminant are the type of organisms which contaminates a culture. It could be at the level of collection, during transportation or during processing. The commonest contaminant is Bacillus species. Moving on to the different types of gram-positive bacteria, Staphylococcus. We differentiate Staphylococcus into two different types, Staphylococcus aureus, which is usually coagulase positive, and coagulase negative Staphylococci. Among the coagulase negative Staphylococci, the commonest one are Staph epidermidis, Staph hemolyticus, Staph lugdunensis, and Staphylococcus saprophyticus. Among the cons, the Staphylococcus lugdunensis is the most virulent. Usually these Staphylococcus aureus organisms, they always cause organized abscess, and 40% of the normal person have Staphylococcus aureus colonization in their anterior nares. Methicillin resistance in these bacteria is usually conferred by a gene called as MECA gene. Healthcare associated MRSA or a community acquired MRSA is always significantly possible. The rates of these infections are not very high in our country as compared to the Western world. Predisposing factors for these infections. When do we get an MRSA infection? People who have prosthetic devices like implants, or they could have a PPI placed in their body. Chronic infections and prolonged hospitalization, patients who have undergone trauma or burns. Immunocompromised and hormonal changes and stress. People who use common towels and razors. Whenever there is a poor personal hygiene due to overcrowding. Regarding the cons, the clinical significance is 80% of the cons are methicillin resistant, which is usually hospital acquired. Among the cons, the Staphylococcus lugdunensis is the most virulent, so the treatment is almost similar to Staphylococcus aureus and most common resident flora on skin. The important aspect of treatment of most cons infection is their ability to form biofilm. So whenever there is a prosthesis, always there is formation of biofilm. So we have to keep in mind whenever a patient comes to us with a prosthetic device. The clinical significance of cons is true bacteremia ranges only from 10 to 25% provided there is a repeated culture presence in the bacteria. Even if the blood culture twice or thrice repeatedly grow cons, that is the time when we need to treat the patient. Or secondly, when there is a clinical correlation of the patient with fever or signs and symptoms of sepsis. The second group of bacteria is a streptococci, broadly divided into alpha hemolytic, beta hemolytic, and gamma hemolytic. The alpha hemolytic streptococci, the two important pathogens are Streptococcus pneumoniae or the Streptococcus viridans. In beta hemolytic, Streptococcus pyogenes, and group B streptococci or the Streptococcus agalactiae. In the gamma hemolysis, it is Enterococcus. The commonest are Enterococcus faecium and Enterococcus faecalis. The clinical significance of pneumococcus, it's usually a normal inhabitant of the patient's oral cavity. But in an immunocompromised status, it can always lead to an invasive infection. Single most prevalent in pneumonia and otitis media. The viridans group, they are the commonest flora or the resident in the oral cavity. The important groups among them are Streptococcus mites, mutans, salivarius, and sanguis. Following dental procedures, they always have a chance of going and implanting on a damaged heart valves or in prosthetic devices, which could lead to infective endocarditis. Streptococcus pyogenes, the blood cultures are positive in more than 50% of invasive infection. Whenever you suspect Streptococcus pyogenes, samples are collected like swab. It has to reach the lab within 15 to 30 minutes. The reason why, because it's such a fragile organism and nutrition deficit that if it doesn't reach the lab on time, it may not grow on the culture plate. Enterococcus. Faecalis and faecium are the most prevalent group of organisms. Their important clinical significance is cephalosporins, cotrimoxazole, clindamycin, and low level concentration of aminoglycosides are not clinically effective for the treatment. Among the gram-negative bacteria, the major subgroup is Enterobacteriaceae and non-Enterobacteriaceae. Among the Enterobacteriaceae, the commonest bugs are E. coli, Klebsiella, Serraceae, Citrobacter, Enterobacters, Shigella, Salmonella. In non-Enterobacteriaceae, which we commonly find in the hospital environment or the hospital-acquired infections, Pseudomonas, Acinetobacter, Stenotrophomonas, or the Burkholderia. Among the lactose-producing organisms, which is the Enterobacteriaceae, Most of the organisms are seen commonly in the GI tract, which we already saw as the resident flora. But the most common pathogenic bacteria which leads to diarrhea or dysentery is the Shigella, Salmonella or the Yersinia group. So they are the most common pathogenic bacteria among the Enterobacteriaceae group. The gram-negative cocci, the common one Diplococci, the Neisseria meningitidis and Neisseria gonorrhoeae, clusters Moraxella catarrhalis. The characteristics of these community and nosocomial infections are: the community onset is usually E. coli, whereas a hospital-acquired infection, the commonest bug is Klebsiella species. The type of ESBL in E. coli is CTX, which is a common ESBL-producing organism. In case of Klebsiella, it is SHV type of resistance or TEM. The type of infection from community due to E. coli is either UTI, bacteremia and gastroenteritis, whereas in hospital, it is a hospital-acquired pneumonia or a ventilator-associated pneumonia or a bloodstream infection. So most of the organisms are not clonally related if it comes to community, whereas in hospital, these are the bugs which leads to outbreak, so they are clonally related with each other. The next, moving on to the non-fermenters. The general view about the non-fermenters are, they are opportunistic pathogens. So they are always acquired, and these bugs, even if they are commonly found in the environment, it doesn't infect a normal person, whereas they are more pathogenic in people who have a compromised immunity. Bacilli, which includes in this aerobic gram-negative, are 10 to 15% of the total clinical isolates, and the most clinical significant ones account for more than 75% in the non-fermenters. The commonest one, Pseudomonas, Acinetobacter, Burkholderia, Stenotrophomonas group. They all are oxidative gram-negative bacteria, aerobes. They are strict aerobes. That means they do not ferment the glucose, but they reduce it oxidatively. Examples are the different aerobic organisms. What is so significant about these organisms in a hospital status? They all are multi-drug resistant, specifically the Acinetobacter. The Acinetobacter has a multiple group of resistance pattern right from carbapinamase production. So the different carbapinamases or the beta-lactamases which the Acinetobacter has got is cephalosporinases, class A ESBL, OXA producing ESBL and carbapinamases. Along with it, it also has a loss of permeability across the porine and an efflux pump. So all these mechanisms play a major role to cause multi-drug resistance in these type of non-fermenters, particularly Acinetobacter. Moving on to the next slide, why specimen collection is important. We have learnt about the different bacteria. Now how to isolate these bacteria in the lab, because the empiric choice of treatment always depends on the culture report, and the culture depends on how you collect them. The basic fundamentals which every one of us should know about the specimen collection is always culture before giving antibiotics to your patients. Ask for smears like the gram stain wherever it is appropriate. Actual site of infection with no contamination. Optimal time of collection. Never send a 24 hours sample. Collect it, immediately send it. Sufficient quantity, appropriate devices. Avoid taking pus swab. Always try to aspirate the pus and send it to the laboratory. Labeled culture container. Do not pour formalin for the microcultures, and no indwelling catheters. Never remove a Foley catheter and send them for culture, because it is not going to give you an appropriate report. Specimen collection and transport. So which collection, when it has to happen, and within what time it has to reach the lab. If it is a blood culture, minimum 10 ml of sample has to be collected per blood culture bottle, and it has to reach the lab within 2 hours. If it's a pleural fluid or ascitic fluid, collect as much quantity as possible, minimum 25 to 50 ml. If the quantities are less, you can put them in a blood culture bottle, but make sure it reaches the lab within 15 minutes. If it's a CSF, for mycobacteria, it is 5 to 10 ml. If it's normal bacteria, 3 to 5 ml, it should reach within 15 minutes. Tissue scrapings should reach within 15 minutes, but the tissue sample always has to be kept wet by sterile water or by normal saline. Sputum, 5 to 10 ml, but never saliva, should reach within 1 hour. Pus sample, as I already mentioned, always an aspirated sample within 1 hour. Deep ulcer with necrosis, collected from the side wall, aspirated with a sterile needle. Never send a formed fecal sample for Clostridium difficile and for hanging drop. Urine and urine routine specimen should reach within 1 hour. The easiest way to remember is whichever sample is highly contaminated, it should reach the lab as early as possible, and if not, you need to refrigerate them at 4 degrees Celsius. Whichever is a sterile fluid, it can reach the lab till 1 hour. Sterile fluid I meant by blood or CSF, you can wait for 1 hour, but if it is a contaminated sample like urine or a bronchoalveolar lavage or an ET aspirate, it has to reach the lab at the earliest, or you need to refrigerate them. So the microbiological diagnosis is basically 2 methods, direct and indirect. Direct methods are the microbiological stains, culture, and also by the subunit detection. Subunit detection we mean by the RNA, DNA, antigen detection of the bacteria. Indirect is usually serological diagnosis, which is the antibody detection or the biomarker detection. So the method of collection of blood cultures are shown in the pictorial representation, how the site has to be prepared with a chlorhexidine in creating a clean area from center to periphery. Always collect 2 sets of blood culture bottle. One set should contain an aerobic and anaerobic. That would increase the yield of the bacterial growth from 60% to 90%. The sputum sample is basically assessed by Bartlett scoring. It looks into 2 criteria, one the number of pus cells and second by the presence of epithelial cells. Whenever the scoring system is less than 0 or less than that means it is a salivary sample and not a sputum sample. You need to resample the patient. Colony forming units per ml is usually calculated for those samples which are not sterile. For example, the urine sample or the samples collected from the endotracheal aspirate, the pus sample. The reason why the lab gives a colony forming units in terms of 10 to the power of 2 in the logarithmic mean, the reason why because they are collected from the most unsterile site where you would have both pathogenic bacteria as well as a commensal. To know the severity of the organism or to identify the true infection, the colony forming units is always given. So for a urine sample, the significance is only proven if the colony forming units is more than 10 to the power of 5. Growth of 2 or more different bacteria is called as polymicrobial growth, and mostly it is a contaminant. So never treat such patients whenever there is more than 3 bacteria in a urine sample. Pyuria is significant if there are more than or equal to 10 WBC present in a high power field. Always correlate such samples clinically with the patient's clinical condition. So the next thing is how to start the empiric treatment or the targeted therapy for the patient depends on the lab reporting the antibiotic susceptibility. Antibiotic susceptibility are done in different ways in different labs. The most common one which is used is the Kirby-Boyer method, which is done with the help of a disc kept on an agar plate streaked by the bacteria. It's usually based on a drug-bug combination where they keep a disc of containing antibiotic in the center of the plate. You can see the zone of inhibition happening across the disc. So the lab measures that zone and tells whether this particular bug is sensitive, resistant or intermediate to that particular antibiotic. The second level of method is MIC. MIC is minimum inhibitory concentration. That is the minimum amount of antibiotic which is required to inhibit the growth of bacteria, which is very important in some of these specimens and certain drugs like vancomycin, colistin, where we do only MIC concentration, and also for certain isolates coming from the CSF, for which MIC is very important. As you can see in the first slide, the presence of inhibition of growth of bacteria at 1 happens. So in this say, 1 is called as the minimum inhibitory concentration. The third level of measurement of antibiotic is called as E-test. Again, a similar agar plate is streaked with the bug, and on top of it we keep a test or the E-strip. It shows us the exponential growth of the bacteria, and the epsilometer or the intersection wherever the epsilometer happens is called as the MIC for that bacteria, by which we determine whether it is sensitive, resistant or intermediate. There are few systems or the automated system available newer in microbiology laboratory. We call it as a microscan, walkway, bioMerio, and the BD Phoenix, which helps us with the appropriate antibiotic of choice, and the turnaround time for these automated machine is less than 24 hours, which helps us to give an antibiotic at the right time for the patient. Putting together the summary of this entire talk is on the clinical significance of different bacteria for the clinical practice, how to interpret them, the different methods of collection and transportation, and the different methods of antimicrobial susceptibility. These microbiology practices would help you out in putting together in a clinical practice. Thank you.